preventing deep vein thrombosis. Until recently, healthcare organizations believed that the formation of blood clots for a certain percentage of hospitalized patients was inevitable. However, current evidence shows that by properly assessing and treating each patient's risk, nearly all blood clots can be avoided, preventing unnecessary deaths as a result.
Pulmonary embolism or DVT, deep vein thrombosis, what it really is it's a blood clot that forms usually in the lower extremities or in the legs, and when it breaks through, it travels up to the lungs. The lungs kind of act as the big filter for the body. And if it's big enough, it can stop blood flow in the lungs and make it difficult, if not impossible, to get oxygen to your body. Things that cause or contribute to it are things that would decrease the flow in your legs. So if somebody's lying around, not walking much, they have a cast on their leg, and if you look at our hospital population, that's a lot of people are in for surgeries, be it on their extremities or otherwise, but also they're sick and they're usually lying in bed a lot.
This complication, also known as VTE, is the second most common complication among all hospitalized patients. It's actually thought to harm as many as 2 million people a year in the U.S. Estimates of death resulting from VTE are anywhere from 60,000 to 200,000 deaths a year that are associated with this complication.
It should have been routine surgery, a case of unnecessary harm.
I can tell you that my first cousin, died of a PE in this hospital in the late 80s. And she died at a young age. She was 56 years old. She had 8 kids. She had, she was a very active member of her community, came in for what should have been a routine surgery. It turned out that she got a pulmonary embolism, which is one of the forms of VTE, and she died before she was discharged. And it was a tremendous loss to my family, of course, but a tremendous loss to a community and of a person who could have had many more years of life. And I think if we can work toward avoiding that kind of loss in the future, we've done a good job.
New tools and new processes. Evidence-based assessment tools for nurses. Helps to identify patient risk factors. Integrates into admissions to cue caregivers. Best practice prevention methods. Enables providers to order proper therapy. Empowers caregivers to administer prevention measures.
And we actually started off doing that as an order set that came with every admission to the hospital. And at the same time, we had the nurses scoring patients for risk and coming up with their ideas as to, on a scale, what people should have. I don't think the order set lasted out very long. I think it lasted months maybe, because what we found, unfortunately, is that it was not being completed, or when people didn't want to go through the whole risk stratification. And what we did find, though, that the nurses were doing an excellent job with their scale. And we looked at it and we thought, well, we have somebody who's assessing the patient in this regard every shift. So every 8 hours, someone's getting fresh eyeballs looking at what their risks are. Because risks change. If you fall out of bed and you break your hip, your risk is different than when you came into the hospital. And we found with nurses doing that, it worked very, very well. And then we decided that it would be better if the nurses took over all of it. And so we kind of got to the point where nurses do the assessment, and if they get to somebody high risk, they initiate a phone call to the provider, who then writes for the anticoagulation order, or at least explains why.
Meeting the challenge. As of July 2007, 95% of patients receive accurate assessment for VTE risk. Adequate VTE. This graph shows the percentage of patients that receive appropriate risk assessment and treatment to prevent blood clots from July of 2004 to the present. Decreased morbidity rate from 3 to 1,000 to 1 to 1,000. VTE cases. This graph shows the number of hospital-acquired blood clots per 1,000 admissions from the year 2002 to the present. equals approximately 20 lives per year. Less patient suffering. Less money spent on health care.